Yep.
All right, cool. So we're going to look at EKGs today. I feel like Matt and Courtney set the bar pretty high. This is going to be a little bit different, a little more interactive, especially at the end. If you guys are driving or just looking on your phone, I'm not going to call in people or anything, but it would be awesome at the end if we're just kind of looking for normal, abnormal, if you guys want to shout something out, and then we'll kind of just go through the examples. So today we're going to look mostly at EKGs. When we were picking topics, I was mostly interested in cardiology, and I know we've had some cardiology. So after talking about it a little bit with Suze, we decided just to kind of focus in and narrow it down a little bit to EKGs specifically for the sports physician, which was a really good review for me. So I'm not going to try to reinvent the wheel. These two gentlemen have done plenty of groundwork for us. So what I'm going to try to do is distill this down into more of a bite size, half an hour, 40-minute lecture. Dr. Dresner, as many of you guys know, is on the left, and he's at UW. He has the really, really good online modules that are free that I recently did after talking with some of you, especially Vosters and Allison, I think Jaffer too. So I am taking a lot of that and trying to distill down kind of his method. The goal is not to replace that, obviously, but instead of reviewing and doing those modules over and over and over every year, my goal is to make something a little bit more bite-sized so that after doing the modules once or twice, this would be more of just like a refresher before doing clearance physicals or being in a situation where you know you're going to have to review a number of EKGs. The gentleman on the right is Dr. Amal Matu. He is essentially the equivalent of Dr. Dresner, but for emergency medicine. So he is like the EM cardiology guru. He has EKG blogs, textbooks, probably thousands of examples by now. He lectures nationally, and he's kind of like the EM Dr. Dresner. So this lecture is essentially taking stuff from both of them and trying to distill it down a little bit. So our objectives today, we're going to quickly review basic EKG interpretation and fundamentals. We'll look over what is considered normal and specifically normal EKG changes in our young athletic population. Then we will review some of the EKG abnormalities that we have to be on the lookout for. And then finally, I have a number of examples. There's a bunch. We'll check the time as we get closer. If we get through all of them, great. If we get through just a few of them, that's fine. And if we get through just a few, we can save this, or I can send it out and you guys can flip through them on your own when you guys have time.
Real quick, not to interrupt you guys, but the examples that he shows, you should make flashcards of them in order to quiz yourself on what's normal, what's abnormal based on age and based on race, because those will be on the test. And they come directly from the article. So all of the examples that Dan's going to go over from the article, those are the EKGs you need to be able to recognize because they take the ones directly from the article and put them on the test.
Yeah, that's really good to know. So especially to pass the CAQ, I would add to that. I was kind of laughing as I went through this. I think that this is something even for more of a practical standpoint. If you're going to be doing physicals like Kent State or at the Browns or something where EKGs are going to be coming through with every athlete, this is really important to review this. I wish I had done it earlier in the year. I know some of you guys did, which was awesome. So yeah, for CAQ, absolutely flashcards for normal, abnormal. And that's pretty much all I think we're going to be expected to know. There's a few specific diagnoses that we'll have to look at, but yeah. Thanks, Mandy. So just looking, remember we have 12 leads, 6 limb leads, and 6 precordial. So my approach essentially, and this is kind of what I've done in the ED, and I think it applies in sports medicine too, is I think that we have like this initial impression and we try to steer people away from that to do this systematic, like type 2, slow thinking, analytical process. And I think it's not an either or. I always try to stress when I'm teaching residents in the ED to use both. So that pattern recognition, as you see hundreds, thousands of EKGs, trust that initial gut reaction that you have, that type 1 quick thinking when an EKG is placed in front of you. And if you have that normal versus abnormal reaction right away, kind of follow that instinct. And then I encourage people to slow down with the type 2 thinking and use a more systematic approach to make sure that you can either verify your initial reaction or pick up on stuff that you might miss if you're just quickly flipping through EKGs. That systematic approach is more of where you slow down, you look at the rate, look at the rhythm, you look at the axis, and then some of the intervals and specific abnormalities that we're looking for. So to kind of review the rate, and I know that this is review, hopefully, I'm not sure if any of the residents jumped on or not, but I always prefer method 1, where you just count the big boxes between the QRS complexes, and essentially it goes 300, 150, 100, 75, 60. Below 60, I just kind of call it bradycardic because I always forget 43 and 38, but you're essentially dividing it by those big boxes. Method 2 is actually a little bit more accurate, especially if you have like an atrial fibrillation or a sinus arrhythmia, higher degree AV blocks, because you can actually just count all of them and then you multiply by the number 6. In a high stress environment, I hate doing math, so I always stick with method 1. But for our physicals where we have a little bit more time, I think obviously either method is very good to use. When we look at rhythm, there's 4 levels of conduction and potential pacemakers in the heart. So just to review that, going from fastest to slowest, we start with our SA node, and if there's any issues or a block with that, the atria then kick in. Likewise, if there's any issues with that, the AV node will then take over, and finally, the ventricles will take over. If you have an upright P wave in leads 1 and AVF, that's going to be your normal axis for a P wave. So if you have inverted P waves there or abnormal axis, you might see flipped Ps in those leads. So that's something to kind of use to confirm that it's actually coming from the SA node and not just like an atrial rhythm. The best way to kind of start to look for rhythm is to verify, and I know we've all heard it, but it's very important to do, to check for a P before each and every QRS, and then to confirm that every single QRS is associated with a P wave. At quick glance, you might miss heart blocks and dysrhythmias if you don't verify that there's a AV association. Atrial rhythms are going to have varying P wave morphologies like we talked about, and the P wave axis might be different, and that makes sense because the place of conduction is coming from a different location. So you won't necessarily have that upright P in 1 and AVF. AV nodal and junctional rhythms, if you remember, those are going to be a little bit slower, probably 40s to 60s for the junctional rhythm, 60s, and a little bit above for the AV nodal rhythms. But the important thing to know is you're still going to have, unless you have a left bundle or a right bundle, you're still going to have a narrow QRX complex. If you have a junctional rhythm that's coming from below the SA node, these might demonstrate retrograde Ps, which is shown on our slide here. So that top lead and lead 2 is a junctional rhythm. You really can't see any P waves. So that's actually coming from the AV node. A similar rhythm is example kind of 2 and 3, where you have those junctional rhythms, but first you see inverted P waves. So they're flipped over because the electricity, the conduction is actually starting at the AV node and going up to the atria. So that makes sense that it's flipped. And then that third example is where you actually see P waves, but they're coming after the QRX. So again, that's a junctional rhythm, but the conduction is coming from the AV node up towards the SA, up towards the atrium. So we see that it's actually retrograde. So either inverted or retrograde with a slower, narrow complex. You want to kind of keep in mind that could be a junctional rhythm. Even if you have a P before the QRS, And even, I would say, even if it looks like a pseudo-normal axis, if that PR interval is super short, you either have to be worried about an accessory pathway like a WPW, or if it's like this, you see that PR interval is almost nothing. This could be a junctional rhythm. So you have to have that upright P with a good normal PR interval for that to be like that normal sinus rhythm. And then lastly, I don't have it shown here, but if you ever see a wide regular rhythm in the setting of a left bundle or right bundle, that could be reassuring, but you always have to consider a ventricular rhythm if you have a wide QRS. Here's a good example of a normal sinus rhythm. At first glance, you might look at this and think, oh, this is abnormal. This is a different type of rhythm. But if you look, every QRS is associated with a P. Every P is associated with a QRS. If you look in lead 1 and in lead AVF, those Ps are upright. There's a good PR interval. So this is a normal sinus rhythm being conducted by the SA node. And this is a good example of respiratory variation in a heart rate kind of corresponding as somebody inhales and exhales. And just kind of keep in mind that you do see that normal P wave axis. So this would be an example of a normal EKG in a healthy athlete. Just to kind of review our different types of non-concerning heart blocks. So this would be first degree as shown above with that prolonged PR interval. You can see there's a little bit more space in between that P wave and the QRS. Very, very common and benign, nothing to really do here. And then that second degree type 1 is you're going to be your second degree type 1, which is Mobitz type 1, which is your Wenckebach. And that's kind of when your PR interval lengthens progressively to a dropped beat. So on this, hopefully you guys can see my pointer, but you have that nice normal PR, lengthens here, gets a little bit longer. And then by that fourth beat, now we're missing a QRS. Then we pick back up and we have that normal P, normal PR, and it progresses again to another dropped beat. Both of these are considered benign and not much to do. And for your test, the second degree Mobitz type 1 is the Wenckebach. And my wife, who was in nursing school, always used to like to say longer, longer, longer drop. Now you have a Wenckebach. So I laughed at her when she taught me that years ago, and here it is stuck in my mind. So I give her the credit. For our axis, this is kind of looking where you have that positive P wave conducting down from the upper right axis down towards the left lower quadrant, if you will, on this graph. And that's why lead 1, you'll have positive deflection for that P wave in 1 and AVF, like we kind of talked about. For our QRS, it's the same thing. So if you remember, if you're positive going towards lead 1, that means it's going towards the left. And then if you're also positive in AVF, that puts you in that normal range for your axis. Once you start to get negative in lead 1, but you're still going down towards AVF, that puts you in the right axis deviation category. And likewise, if you're going away from AVF but towards lead 1, you get that left axis deviation. And you just have to remember, you know, as you go through EKGs, I think in med school, we do a poor job of just showing EKGs and trying to memorize what is this EKG. And at least in the ER, what we try to do is teach that EKGs, you know, like a white count or a temperature, there's a broad differential. EKGs are no different. When we have a left axis deviation or a right axis deviation, we try to teach people to consider what is the differential for those things. Most of the time in older people, left axis deviation will be because of left ventricular hypertrophy, but WPW, LVH, HOCM, MI all cause left axis deviation. And likewise for a right axis deviation, you can get a slight right axis deviation with an incomplete right bundle, which can be normal in a young athlete, but you can also get it with cor pulmonale, pulmonary hypertension, COPD, pulmonary embolus, MI. So just kind of when you find something on an EKG, and instead of trying to say, what is this? I think a better question is to potentially ask, what could this be? And what is the differential? So Mandy kind of mentioned the article, and we're kind of getting into it now. So this is the consensus statement that was put out by the AMSSM. This is going to be very high yield for our exam. And this publication put out by Dresner and his group is what the modules online from UW are based on. They're available, they're free. If you haven't done them, you absolutely should do them. This should not replace that. But talking with some of you, I think I agree that it was worth maybe distilling some of it down, especially right before test prep. This might be something good to review. So here's the most important table, I think, that kind of came from that. And in the green, you see a list of all of the normal EKG findings. So like we talked down at the bottom, you have your Mobitz type 1 second degree AV block, that's your Wanke block, your first degree AV block, prolonged PR interval. Other things are sinus bradycardia, T-wave inversions in leads V1 through V3, and people less than 16 are normal. So if you're seeing mainly adults and you get really nervous with T-wave inversions, keeping in mind juvenile T-wave inversions less than 16 years old, V1 through V3 is normal. And similar, if you have ST elevation followed by a T-wave inversion in V1 through V4, in Black athletes, this also is normal. So like Mandy mentioned, keeping in mind the race of your athlete. And sometimes, ideally the patient's sitting in front of you for a physical and you're handed an EKG. Sometimes you just have a stack of EKGs. And this is where it becomes important to know, who is this EKG? Who does it belong to? What's their age? What's their race? Because then the criteria are very different. The abnormal EKG findings we'll get into more, but I think it's probably a good place to start with what is normal. So these are the common physiologic EKG findings related to cardiac adaptation in a trained athlete. So most of our people, especially at the collegiate and professional level, are going to have some of these changes. Voltage criteria for LVH, early repull, right bundle, juvenile T waves, that Black athlete repolarization variant that we discussed, and then junctional and ectopic atrial rhythms can also be very normal, especially at lower rates. So you'll see some athletes that'll have a junctional rhythm when they're resting, a marathon athlete with a heart rate of 48 at rest who is junctional and then maybe flips up into a sinus rhythm at 85 during exertion is not uncommon. To keep in mind what our criteria are for LVH, there's different criteria. The one that I like to use is the S wave in V1 plus the R wave in V5 greater than 35 millimeters is LVH. This alone in young healthy athletes does not need further testing. Your right bundle branch block, a full right bundle can be abnormal. The incomplete is what is normal, and that's going to be your RSR prime with a QRS, importantly, that's still considered narrow. So you don't have that wide QRS. So it's very important that the QRS is still narrow, and that's what kind of keeps it incomplete. Wide QRS complexes are not considered normal, and those could represent conduction delays that warrant actually additional workup. So just keep in mind incomplete versus complete. Juvenile T waves, we kind of discussed V1 through V3, less than 16 years old. That's normal in healthy athletes, regardless of race. When we start to look at T wave inversions beyond V2 and athletes older than 16, that is not normal unless it's the Black athlete with benign early repull. So that's probably one of the more important takeaways from here. If you have an athlete less than 16, T-wave inversions V1 through V3, totally fine. After the age of 16, you can accept T-wave inversions V1, V2, but after V2, when you get into V3 and V4, it's not normal unless they're Black with a benign early repull. And then just as importantly, T-wave inversions in leads V5 and V6 are never considered normal. So that does not fall under that Black athlete with benign early repull. Just to show that as an example, here's normal variant versus pathological T-wave inversions. So as you know, this still as an ER doc, panel A still makes me a little bit concerned. And I think if somebody comes into the ED with a active chest pain radiating to the left arm and jaw and multiple risk factors and they're 78 and I see this EKG, I'm extremely concerned. If I have a 17-year-old black marathon runner and who's asymptomatic and I'm handed this EKG, this is normal. So you see those T-wave inversions, V1 through V2, actually extending into V3 and V4, but you also see the benign early repull with the dome-shaped ST elevation in those leads. And again, just as importantly, in V5 and V6, those T waves are not flipped. So this panel A is considered normal in a black athlete. Panel B, we see those T wave inversions, and this is not normal for a couple of reasons. One, we don't see the benign early repull. Two, we actually see diffuse ST depressions. And then three, we see those T wave inversions that are extending into V5 and V6. So you could see similarities between these two. Panel A normal, panel B abnormal, should not exercise, should not participate until getting a further workup. That brings us to our next slide. This is where we identify any EKG findings that warrant further evaluation to confirm or exclude cardiac pathology. That's going to include the T-wave inversions that we talked about, not only V5, V6, but commonly those will be associated with 2, 3, and AVF in those inferior leads. ST segment depression, bad. Pathologic Q waves, bad. And then pre-excitation pathway, short PRs, any evidence of the delta wave and WPW, also bad. So in kind of the spirit of recognizing and making a diagnosis, these are listed because step 2, once you identify that something is abnormal and form a differential, these would be things on your differential. Again, though, if you can say, hey, this person definitely has Brugada, or this person definitely has arrhythmogenic right ventricular cardiomyopathy or ARVC, that's great. I don't think you get bonus points, though. And I think one of the big takeaways from Dr. Dresner's workshops were just recognize normal versus abnormal. And if something is abnormal and you refer it, they are going to catch it. They're going to do a cardiac MRI. They're going to do further testing and the life has been saved, right? Certainly you can say, I am concerned for LVH. I'm concerned for long QT. But just, if you have anything to choose, just memorize the things that are abnormal so that you can hold somebody and get more information. Looking at that list, though, the first on it was hypertrophic cardiomyopathy. This is an EKG example. The top one, you can look at the left axis deviation, first of all. So you're down in AVF mostly, but you're still upright in 1. So that's putting you into that left axis deviation category. And part of that differential is going to be your hypertrophic cardiomyopathy. You do see those big S waves and tall R waves here, greater than 35 millimeters. So you have LVH with ST segment depressions and then these deep lateral T wave inversions. When I was taught to look for HOCM or HCM, it was always pathologic Q waves, dagger Q waves, LVH, and a murmur, right? Well, murmurs can be really hard to hear depending on the setting. This patient doesn't have those pathologic deep dagger Q waves, and they do have LVH, but unless your eye is really drawn to these lateral T wave inversions, you could theoretically miss this. So again, V5, V6, T wave inversions, abnormal. Lower EKG, you can kind of look at the inferior lateral T wave inversions. So this is where it's also involving 2, 3, and AVF, and V5 and V6. With those ST segment depressions. This one does, if you look kind of closely, you can start to see some Q waves, I think here, but again, those lateral T waves. So a lot being said here about HOCM, but when we distill it down, you can look V5, V6, V5, V6, both have T wave inversions. That's abnormal, hold them out, right? So nice and easy. Inferior lateral T wave inversions should typically be evaluated with an echo and cardiac MRI to assess for HOCM. And then even if they're cleared by cardiology, if you're going to be a team physician, these patients should still be followed annually. We saw a little bit of this at the combine where patients had cardiac MRIs, they had their echoes, they were okay. But then the recommendation was, hey, whoever ends up taking this player every single year, they should be followed with serial testing. And that's because this article actually showed that many will go on to develop pathology later in life. So this is important for anybody, again, doing team coverage after fellowship. 81 patients were in this study, and they had EKG findings that were concerning. And this was done at a 9-year follow-up. And of those 81 patients, 70 were okay. And these were all 81. They were initially fine with their initial testing. They were cleared to participate. But at 9 years, 70 of them were still okay, but 6 actually developed cardiovascular disease, 5 had cardiomyopathies, and 1 of them actually had sudden cardiac death. So you see the EKG changes, they're worked up, card says negative, they're cleared, that's fine. There's still a small risk that they're going to go on to get more abnormalities and develop pathology. So every year they're going to need more testing. To review what arrhythmogenic right ventricular cardiomyopathy is, this is something called an epsilon wave, and it's always going to be a positive, tiny little positive deflection after the QRS complex in lead 1. You will still see those inferior lateral T wave inversions, but kind of keep an eye out for that very small positive deflection in V1 after the terminal QRS to kind of give you a clue that this might be ARVC. Again, in dilated cardiomyopathies, you'll still see the inferior lateral T wave inversions. Here we also see precordial leads with the deep S wave in the V1 through V3. And then you have poor R wave progression. So you just never see that R wave take off as you kind of work your way from the anterior septal to the lateral leads. So if the atria are also dilated, you can look out for large P waves. You kind of see that here in leads 2, 3, and AVF. It's not that the P wave is very big, but the P wave is pretty big compared to the QRS. And that's something that Amal Matu always draws your attention to, is when you're looking at for the size of the P wave or the size of the T wave, normal size with a small QRS is actually abnormal. So if you have low amplitude secondary to habitus, COPD, et cetera, everything should be low. So I would say that that P wave looks normal, but because the QRS is teeny tiny, I would actually say that this P wave is dilated because of their dilated cardiomyopathy, putting more stress on the atria. Left ventricular non-compaction. This is another type of cardiomyopathy with similar EKG findings. This was something that I honestly was not really familiar with at all until I did these modules and found that this would be something else on that differential. Here's what the EKG kind of looks like, and you see that they can also present with those isolated T wave inversions. It can look very similar to hypertrophic cardiomyopathy. But above, this is another example of a patient with this type of cardiomyopathy that presented with a sort of diffuse ST segment depressions. So again, T wave inversions in the lateral leads or ST segment depressions, those patients need additional testing. Long QT syndrome, I threw on here MD Calc. There's different types of formulas to kind of calculate what the QTC actually is. Normal is less than 470 in males, 480 in females. Remember to get serial EKGs and ask about medications. So they could have congenital prolonged QT syndrome. It could also be medication induced. So if they're on a macrolide or honestly anything, if you look up the list, it's really crazy what all can prolong a QT interval. This is the link kind of to MD Calc to look for that corrected QT interval, to throw it in there to actually make sure that the computer is correct. Here's an example where the QTC is close to 700. And this is not subtle at all. For everybody that is wondering, our girl from the marathon, she was in fact found to have long QT syndrome. I think she went home yesterday and the day before had a defibrillator placed. So these patients obviously are at risk for sudden cardiac death secondary to a ventricular dysrhythmia, especially with exercise. And what happens is that T wave should be sooner, and since it's later, as you speed up the heart rate, what you risk is that R on T phenomenon, where the QRS and ventricles depolarize when right on the T wave when they're actually supposed to be repolarizing, and that puts you into most commonly VFib. Here's Brugada. This can sometimes be mistaken for a STEMI or active ischemia, but that downsloping in V1 or the saddleback noted in V2 is kind of what you're looking for. And this is a sodium channelopathy, which is what causes this. Patients will present with syncope. They're also at risk for sudden cardiac death. There are 3 types. Type 3 is very difficult because it can either present with that downsloping or the saddleback. It's just the difference is you don't see that obvious ST elevation in V1 and V2. So I usually just consider this 2 types and just look for a downsloped like ski slope for type 1 or a saddleback ST segment with or without ST elevation, to kind of, obviously with a good story for it, like something like syncope. WPW is something else that we're going to look for. You're going to have that short PR wave, delta wave, a prolonged wide QRS. It might not be fully wide because what happens is as the conduction starts to go down from the SA node in the atria through the accessory pathway, since you're bypassing the normal conduction, that delta wave, as you can see kind of like in the precordial leads here, you can start to see that QRS initially starts out as wide, but then the conduction, it either rejoins the correct pathway or partial conduction will catch up going through the AV node, and then the rest of the QRS complex is narrow. So you can have a widened QRS. You can also have a partially widened QRS with just a delta wave that's followed by a normal narrow QRS. But the important thing to look for here is that short PR interval. That's what's going to kind of clue you in. It's important because pre-excitation can actually be associated with Epstein's anomaly and cardiomyopathy with right-sided heart failure. And thanks to, I think it was Voster's who reminded me what Epstein's was. Appreciate you, man. AV blocks, again, type 1 PR prolongation normal. Mobitz type 1 Wenckebach normal. Mobitz type 2, where you don't see that progressive PR interval lengthening with random dropped beats, you just see, or with drop beats, you just see random drop beats, is bad, and complete heart block is also very bad. So this is where it becomes important to look for that QRS after every P and a P before every QRS. All right, so I don't know, we're at 9. So let's do maybe 10, 15 minutes max of examples. And again, I can send this out, and I'm not even looking for a specific diagnosis. If I hear crickets and nobody says anything, I'll just tell you guys and we can flip through it. But the main thing is you're handed an EKG and you should say normal, play, abnormal, don't play, right? Or abnormal, more tests, referral. So here's our first one. This is a 28-year-old male football player. Right rhythm axis, a little bit bradycardic. See some early repolarization. We do see LVH. This is a normal EKG, nothing to do. At first glance, you might say, hey, there's LVH, there's some ST elevation in these precordial leads that even extends out to V4, V5, but you see that nice J point elevation in these precordial leads without reciprocal changes, no T-wave inversions, young, healthy athlete. This is benign early repol, normal. Let this person play. There's nothing to do. Here's a 20-year-old black track athlete.
Abnormal. T-wave inversion V5, V6.
Yeah, I love it, Matt. Thank you. Yeah. So at first glance, you have that domed ST elevation in the precordial leads with the T wave inversions. And we said, hey, Black athlete, this is normal, right? But just like Matt said, it actually extends out V5, V6. And I'll raise your V5, V6 to also the inferior leads 2, 3 AVF. So that is always abnormal. This patient should not play and needs referred. Yeah, good job. It's a 12-year-old male basketball player. So we said definition of juvenile T waves, less than 16, right? So less than 16 years old. You can have V1 through V3. T wave inversions, make sure that you have that nice dome shaped in those precordial leads. And importantly, you don't see any ST depressions. So this would be considered normal juvenile T waves, regardless of race of athlete. This is going to be normal, nothing to do. 18 years old, basketball, female.
Abnormal, they have delta waves.
Yeah, love it, love it. So short PR, delta wave. QRS actually looks a little bit wide. Again, we see a left axis deviation, down in AVF, up in lead 1, all consistent and concerning for WPW. Going a little bit above and beyond, you see that abrupt cessation, like where the delta wave just quickly goes upstroke. That does likely mean that this is a low risk pathway, meaning that it's going to be unlikely that they will progress into a ventricular dysrhythmia. So it does make you feel a little bit better. But still, this is going to be a referral. They're going to need cardiac testing, probably EP to look at this. Absolutely. Yeah, good job, officers. 23 years old, male.
Abnormal with the T wave inversions again.
Yeah, love it. And V6 is kind of subtle. I mean, yes, you can kind of see it, but one of the reasons why I included this one is this is abnormal, and it doesn't have to be V5 and V6. It can be either or. So if you see that T wave inversion, either one, this patient's going to likely need an echo, needs referred, abnormal. Good job. Crushing it, man. Here's a 15-year-old white male baseball player.
This one I think is normal.
Normal.
Yeah, I like it. What do you guys see?
Incomplete right bundle branch block.
Yeah, I love it. So RSR prime, V1, but you have a normal axis. That QRS is nice and narrow. This is an incomplete right bundle. Nothing to do. They can play. Yep. 24 years old, male basketball. So this one I included because this is a little tricky. You see the normal T waves, but you actually do see LVH, which would be considered normal if not for those dagger-like Q waves in V4, V5, and V6. So, this is something that I think I even missed this the first time I went through this. But when I try to go through EKGs, and when you're looking, it's that rate rhythm axis. And then looking at your P wave morphology, and then literally systematically going through the P, PR, QRS, QT, T, And then even your T to P interval, and just looking at that in all the leads. So this would be somewhere where you're like, LVH probably fine. P waves look good. PR looks good. QRS, well, first of all, Q, do I see any Qs? Yes, right? So this would be something where if you're not looking for the Q waves, you might miss this, but this is actually HCM. So this patient needs referred. Ideally, you would also hear a murmur or something, but this one's a little tricky. Here's a 29-year-old male, chest pain after lifting weights. Again, see some LVH, no Q waves, ST elevation, but J point, right? And the age kind of fits with benign early repole. There's no reciprocal changes. This is a normal EKG, nothing to do. Last few minutes, let me just fly through the rest of our examples. Here's a 24-year-old male Black athlete. You see the inferior lateral. Sorry if you hear Lucy, guys, in the background. I shut the door, but she hears me in here. You see ST depressions, which is not good. And then those T wave inversions extending out, inferior lateral, abnormal, refer. 18-year-old white male. This is going to be a dilated cardiomyopathy with a high-grade AV block. So you see AV dissociation, you see Q waves, not good. This should be an obvious example, needs referral. Here's an 18-year-old female, junctional escape rhythm. So here's one of our examples where our P waves are buried kind of after, and sometimes like after the QRS, and maybe even a little bit before in some places. So this is going to be normal though, and can be a variation of sinus arrhythmia or normal sinus rhythm. Here's somebody, 30-year-old female with syncope at practice. Consider your differential for syncope, WPW, ARVC, long QT, Brugada, right? And if you look, V1, V2, down sloping, this is an example of Brugada. Patient needs referred, do not let them play. 24-year-old soccer player, long QT. 17-year-old rower. We see some inverted P waves in the inferior lead. So this is an ectopic atrial rhythm. But remember, that can be normal in our athletes. So this is actually nothing to do. Normal EKG. Last example, as an ER doc, I look at this and I think it looks horrible. This is a normal EKG. So 28-year-old male Black athlete, benign early repole with those dome-shaped ST elevations, those deep T wave inversions that do not extend to V5, V6, completely normal, nothing to do not refer. So just some take-home points here before we wrap up. Again, you can kind of focus on specific diagnoses, but just kind of try to remember the normal variants, and then the things that you should always kind of pay attention to, ST segment depressions, pathologic Q waves, pre-excitation pathways, and those inferior lateral T wave inversions, and hold those patients out. I remember asking a question earlier in the year about concussion with a difficult patient I had, and one of the things that Mandy said that stuck with me was, that's actually one of the easier things because of our guidelines and everything that's put in place. When you're dealing with concussion, we're now at a point where it's very black and white. Concussions do not play. I would argue, I don't know if it's always been like this, but especially with the Damar Hamlin and things recently, if you have an EKG that you're slightly concerned about, I highly doubt you're going to get much argument from parents and athletes. This isn't like a my ankle hurts, please let me play. This is a go, no go type situations. And as you guys have, please feel empowered to hold people out, because like we saw last weekend at the marathon, these people can die.
I will pipe in and say, I will disagree with you about the people not caring if you hold their kids out.
Okay.
So we've had full stop legal battles at some of the schools over holding people out who have known diagnoses of long QT. We've had a couple years ago when we did mass physicals, the first or second person who came through the line had a family history of mom and aunt with ARVC, and she had never been worked up. And I think she had not reported it the prior year. So she went through her mass physicals and got cleared, came through, reported the family history of ARVC, and I held her out. And it was a full on like political nightmare for James. She was literally on social media, posting horrible things about us, telling people downstairs in like the line that they shouldn't send their kid through mass physicals. Like, it is so contentious. So we think, oh, we're just doing the right thing. We're trying to make sure the kid's safe. But when it comes down to it, people want their kids playing. So you can say it shouldn't be contentious, but it's absolutely contentious, even in situations where there's clear indication that they need cardiology workup.
So
the other take home point, I think I learned two things pretty early on taking care of case. One, people lie and don't report all their stuff. So we had a situation where we literally had a football player who came through the line and literally had just hit no on every box going down the physical form. And the resident had him lift up his shirt to take a listen to him. And the kid had a sternotomy pretty much all the way down his chest. He'd been zippered open. Well, what's going on here? Oh, well, I dropped dead playing basketball, but they saved me and I'm good to go now for football. So, like, people don't report information and they purposely hold information back because they want to be cleared. So especially when you're in that college situation where the kids show up to college and may not know all the family history, or even as you'll learn in mass physicals, when people show up and there's no parent going through the line with them, you have to take the extra time to try and clarify information. And even if somebody says they have a known clearance from cardiology, I do not let anybody participate until that cardiology clearance is in hand, even if they say they've been cleared before, because I had a case athlete do that many years ago who's like, yeah, I'm just getting followed. It's not an issue. And their paperwork showed up and they were a known diagnosis of hokum. So, like you can't trust anybody because people want to play. So, I just caution everybody, we definitely learn, I would say, Mandy and I together at Case had some really interesting situations in the first probably 5 years I was in practice. It just taught me a boatload. And you're never wrong holding somebody out until the workup is complete or till you see the documentation that the workout has been done already. So even if it pisses people off.
So at least black and white for us.
Right. Well, and the other thing to remember is college athletes, even the case kids, have no freaking clue what their family history is. I had identical twins come through with a completely different cardiac history. Unfortunately, they were from the area, so mom was, able to be contacted, and she was like, "Oh my God, here's the deal." Like the kids had no idea what their family history was, really. So trusting those histories we see at these mass physicals is a huge issue. And so we are likely clearing people who should be getting screening EKGs. Just because people don't know, they just reflexively check all the no buttons. So it is very tricky.
Well, thanks, guys.
Great talk, Matt.
Any other questions?
Dan, I should say Matt. Yeah.
Matt helped a ton. Yeah, thank you.
You can tell I'm half awake today.
That was great. Thank you.
Yeah, sure.
Thanks so much.
Thanks, Dan.
That was awesome, Dan. Thanks.
Take care.